So hi there, my name is Emma. I'm from the Yinova Center. Before we dive into our discussion today on PCOS, for those of you who are new to either RMA or Yinova, I wanted to let you know a little bit more about both of these centers, as well as tell you a bit more about our speakers. So RMA of New York are leaders in state-of-the-art reproductive medicine. Their fertility clinic is led by an integrated team of doctors and scientists with extensive experience in fertility testing, IVF, egg freezing, and LGBTQ+ family building. They're offering virtual consultations and have also opened their doors for fertility procedures. The Yinova Center is an acupuncture and Chinese medicine clinic based in New York City. We specialize in fertility and reproductive care. As of recently, we've moved part of our practice online, where we've been offering virtual consultations to support our patients, but we've also reopened our clinical doors as well and are available for in-clinic acupuncture. Dr. Tanmoy Mukherjee is a co-director of RMA of New York, an associate director of the Mount Sinai Division of Reproductive Endocrinology. Dr. Mukherjee is the author of numerous journal articles and textbook chapters and has written extensively on the diagnosis and treatment of patients with recurrent spontaneous miscarriages. He specializes in a wide array of medical and surgical treatments for the management of endometriosis, uterine and fallopian tube abnormalities, and abnormal uterine bleeding. A testament to his experience and dedication, Dr. Mukherjee has been named on the New York Magazine's list of best doctors of New York for 18 consecutive years and recognized as a New York super doctor for over a decade. And then we have Jill Blakeway, who is an acupuncturist and herbalist and the founder of the Yinova Center, where she's been treating patients for over 2 decades. Jill has been passionate about helping people achieve a healthy pregnancy, so much so that the New York Times has described her as a fertility goddess and named her as one of Manhattan's top acupuncturists. She credits much of her success to combining the ancient wisdom of Chinese medicine with modern conventional biomedicine. To this end, she joined forces with a reproductive endocrinologist to co-author the best-selling book, Making Babies, a proven 3-month program for maximum fertility, about how to conceive naturally. She's also authored 2 other books on health and healing called Sex Again, Recharging Your Libido, and Energy Medicine, The Science and Mystery of Healing. I know many of you have sent over some questions prior to this discussion, which we are looking forward to diving into and answering. So with that, I'm going to pass this over to Dr. Mukherjee and Dr. Jill Blakeway to get started.
Thank you, Emma.
Hi
there, Dr. Mukherjee. As Emma was reading all of that and saying it, I realized how long we have done this and how long we have known each other.
Let's not embarrass ourselves with those details, shall we? Every day is a new day.
I was like, yes, for all those 18 years, he's been on the best doctors list. He has, in fact, been my friend, Dr. Mukherjee, and I have done this for over 2 decades now. So we have worked together for a long time looking after our patients, and it's always a joy to get together and do these webinars. And I wondered if we should start by just explaining what PCOS is. And I thought maybe you could start there and I'll sort of add in my take. But what is PCOS? What
Great
causes
question,
it?
Jill, and thank you for having me here this evening. And thank you for that wonderful introduction. I'm blushing, but thank you for that introduction. PCO is unfortunately one of, I think, the most misunderstood conditions in all of infertility. When you look at the name polycystic ovaries, immediately you can sense the panic once that statement is said aloud, because cysts, oh my goodness, what does that mean? I've got cysts on my ovaries. And unfortunately, it's nomenclature that we shouldn't be using, but it's so embedded in the literature, it's hard not to use it. So we want to look at how it's diagnosed. And then we have another problem, because the diagnosis of this is terrible. There are a lot of different conditions that funnel down into a very similar appearance. But if you want to be technical, number 1, irregular menstrual cycles. And the fact of the matter is, very few women actually have 28-day cycles. So if your cycles are anywhere from 26 to even 32 days, that's pretty typical. But if you're going 35, 40 days without a cycle, that fulfills the first part of the diagnosis. The second criteria or level of testing that you need is hyperandrogenism or hyperandrogenemia. What does that mean? Excess hair growth. If you develop hair in non-sexual areas, on your face or on your chest, along those areas, that's a concern. Or if you have oily skin, or in your blood, if you have an elevation of testosterone or DHEA, that also fulfills the second part of the diagnosis. The last part of the diagnosis, the classical part of the diagnosis, is the exclusion of other medical problems. And that's where people really consider PCO to be a garbage can diagnosis. It's primarily made by excluding other conditions. What's going on with your thyroid? What's going on with your pituitary? What are your prolactin levels? Are you diabetic? Is there a problem with cortisol production? Is there an enzyme block? You have to go through a litany of these other tests to show what it is not a result of before you can back into the diagnosis and say, you have PCO.
And you don't necessarily, Dr. Mukherjee, do you have to have the little classic string of pearl cyst to be diagnosed?
Not at all. The ultrasound appearance of PCO can be quite variable. There are some criteria that employ an ultrasound determination, but I've seen plenty of patients who have normal appearing ovaries, but they have irregular menstrual cycles, they have elevated androgen levels, and everything else is okay. So technically, they are PCO as well.
One of the things that Dr. Mukherjee alluded to there, and I agree with, is that we call it PCO, but we'd probably change the name now if we could, if it wasn't all over the literature, and that's what we call it. Because it really is a sort of complex metabolic disorder at its heart. And I always explain to my patients that right at the very root of PCOS, and we don't really know what causes it. It looks a little bit genetic, doesn't it? But there's some sense that it runs in family.
Genetic predispositions, but what tips you over?
Yes, but I think it's sort of a trifecta that tips you over, which is a sort of overactive immune system, consequent inflammation, and insulin resistance. And the inflammation, to cut a long story short, increases very specific proteins that suppress insulin signaling and make the body less responsive to insulin. And then your pancreas goes into overdrive and makes more insulin to compensate. And that triggers the ovaries to produce androgens. And then the elevated androgens lead to these erratic periods and things like acne, don't they, and disrupt ovulation. And then those follicles that should have ovulated just keep growing and could form cysts. And one of the other issues that I see a lot is that because those follicles just keep growing and there isn't a luteal phase of the cycle, there's often estrogen dominance too. That's a very sort of estrogenic phase of the cycle. So people end up having too much estrogen, and that is all part of weight gain as well. So it becomes a bit of a vicious cycle. The insulin resistance and the estrogen dominance cause weight gain, and then the weight gain leads to more inflammation and more estrogen dominance because fat is estrogenic, and more insulin resistance. And that is at the bottom of it, isn't it? Have I done that okay?
Of your cycle, and you know, and your background in Eastern medicine values this balance that needs to exist for successful reproduction. And when we see PCO in its most essential state, it's completely out of balance. This menstrual cycle that needs to go on, where you have egg growth, ovulation, uterine lining shed, it is a cycle, and there's a lot of different entry points for insulin resistance, for poor diet, for as you're getting older, carbohydrate intolerance, and maybe inflammatory states that result in poor nutrition and digestion. But I think the biggest connection, at least in my experience, is that connection with insulin, because insulin receptors, there's very similar receptors in the ovary to the insulin receptors, the IGF-1 receptor. And when you have this abnormal insulin regulation, you trigger the follicle's IGF-1 receptors, and everything gets thrown out of balance. So that's one very elementary means of looking at it. There probably are other layers to it, but for me, I think that's the strongest connection, because oftentimes we do see issues with BMI in patients who have PCO. But when you ask them, what were your cycles like when you were younger? Well, when I was a teenager, it was irregular. Then it became regular. And then it became, when I was in my 30s or after I got married, it became increasingly irregular. And oftentimes you'll find that there's a significant weight gain from that earlier point in their lives to, the weight gain that comes with marriage and so forth, which I can speak to personally.
I can too.
Also, it can affect reproduction. And oftentimes I ask them to see our nutritionist and work on their insulin levels, carbohydrate restriction. Intermittent fasting, I think is a tremendous new avenue to kind of look at how insulin metabolism can be affected, because not eating for 12 to 14 hours may not be such a bad thing. I've spoken to physiologists, I've spoken to health physicians who are advocates of intermittent fasting simply because it rests your pancreas. So you're not making insulin 24 hours a day, not eating something right before you go to bed. So you're still making insulin 3 to 4 hours after you're asleep. There may be some benefits to it.
Yeah, and the reason that I sort of went back to the root, and Dr. Mukherjee's right, I sort of like the root of things, but I also mention it because it does mean there are some things you can do. And I think sometimes, you know, a diagnosis can feel very stalling, and it's not your fault that you got PCOS at all, but there are ways to manage your way out of it when you think about insulin resistance and inflammation and the sort of the suppression of your body's communication system. And Dr. Mukherjee will tell you that I am a big believer that there is a part of our body that we just take for granted. And that is our body's ability to just keep it, bringing us back into what's called homeostasis, into balance. You know, we have a couple of extra drinks at dinner and our liver, as long as we don't do it all the time, kicks in, sorts that out. We never have to think about it. You never think, oh, I must ovulate next Tuesday. It just happens. And so there's a lot going on in your body autonomically. And in order to do that, your body has very complex and sophisticated feedback systems. And I think a lot of chronic disorders, and I count PCOS in this, are disorders of miscommunication, overreaction, that kind of thing. And there are things you can do to help your body get the plot again and get back into balance. And diet, as you mentioned, is one of them. I wanted to throw into the mix, along with intermittent fasting, which I think works very well, is the autoimmune paleo diet, which is an anti-inflammatory low-carb diet. My patients do particularly well on that because it deals with two of those root causes. It's very low in carbohydrate and the sort of foods that set off inflammatory reactions in people's bodies.
Oh, I agree. And how do you counsel your patients as far as the paleo diet? What should they be focused on? What should they be avoiding?
Well, this is even one step further than the paleo diet. And I hate to drive people nuts when it comes to diet. Do you know what I mean? So I'm one of those practitioners who's like 80% is perfection, etc. However, actually with PCOS, what works is to have very low carbohydrates altogether. So we cut out starchy vegetables and grains and beans, unfortunately, which I love and think are very healthy and good for you in other ways. Lots of leafy vegetables, lots of non-starchy vegetables, limited fruit apart from berries. And then we cut out the common inflammatory agents, things like a lot of people react with inflammation to dairy, for example, corn, soy. Is another one.
Processed foods, I imagine, a lot of the modern
diet. Anything with lots of E numbers, anything that's made in a factory, which leaves you with, I know, because people always then say, well, what on earth will I eat? But it leaves you with lots of healthy oils, which are really good for you, lots of olive oil. This is kind of Mediterranean-y type eating.
Well, the Mediterranean diet is what I recommend to my patients because I think it has a lot of features to it that are ideal for the treatment of a lot of what ails us, and certainly PCO. It hasn't been shown, but if there's any diet I think that would be helpful, it would be a Mediterranean style diet.
I think so too. Healthy oils, nice, good quality protein in relatively small amounts, lots of veggies, cut down on the grains and the wheat and the dairy, and also take a good probiotic. 80% of our immune system is actually in our gut. So an imbalance of gut flora is often the cause of inflammation and an overactive immune system. So I think a good probiotic is also another good idea. And because estrogen dominance is part of this. If you're just building follicles and for days and days longer than you should, and you have you then have a dominant estrogen in relation to progesterone, you shouldn't be adding any chemical estrogens. Xenoestrogens is what we call them. So all those household products that are endocrine disruptors, household cleaners and things like that, you can come and talk to us at the Yinova Center. We'll help you clean out your cupboards, but you should get rid of and skincare products are notorious for having endocrine disrupting chemicals in. And Dr. Mukherjee gives people pharmaceuticals the whole time by patch, don't you? You give people estrogen patches. So what you put on your skin does go through.
Yes, Absolutely.
Yes, it does.
You get absorption. Certainly estrogens. Progesterones are a little bit more complex, but estrogens.
Yes, estrogen goes through your skin. So you should not have estrogen mimicking chemicals on your skin, and a lot of skincare products have them in. So we have some questions, and this one is a good one for you, Dr. Mukherjee. It says, if a cycle is 100+ days long, what is the likelihood that it will be a good follicle for fertilization?
Well, what you have to keep in mind is that during that 100-day period, it's not a single follicle that's governing that. What you're having are these waves of follicles that usually are limited to lifespans of no more than 30 or 40 days. So you're not, the best way to answer that is back it up. How do you get a regular cycle? So you have one egg that matures, it ovulates, then the follicle that's left behind after the egg is extruded makes progesterone. Progesterone acts on the uterus to cause a withdrawal of that uterine lining, that bleed, if you are not pregnant. So what's missing in that 100-day stretch is any production of progesterone, that trigger that the uterine lining needs to say, okay, my lifespan is over, I have to shed and start over again. So what you're having is this egg that has grown, it makes a little bit of estrogen, but doesn't ovulate. Then another egg takes its place, then another egg takes its place, and another egg, but none of these eggs are making progesterone. So at some point, the lining either gets so thick or so abnormal that it just breaks down, it just dies, or one of these eggs will now make progesterone and cause the lining to shed. So it's not one egg that all of a sudden is now living for 100 days. It's groups of eggs that fail to ovulate, that continually make estrogen and stimulate that uterine lining until that lining cries uncle and just breaks down, or you have a withdrawal bleed with progesterone. So you have breakthrough bleeding, which is where the lining collapses, breakthrough, or you have a withdrawal bleed where progesterone is elaborated and the lining sheds on the signal of progesterone production.
So what you're really saying is it's not just about fertilization, that egg, is it? It's about a receptive lining, and the synchronization is completely off by now, so you don't necessarily have a receptive lining.
Right, the uterus is essentially passive, and it responds to the signals that it's getting from the ovary. And if it doesn't get that progesterone signal, the lining will remain static.
This is one of these communication systems that I like so much. I mean, when it works, it's amazing. It's absolutely amazing that the follicle leaves, becomes the corpus luteum, and on a conception cycle, it receives a signal to keep going, and on a non-conception cycle, it starts to disintegrate, and you get your period. It's very clever.
It's very clever and very intricate, and sometimes I'm amazed that we're all here at all. But.
I know. When you work in fertility medicine like we do, you are impressed that people get pregnant. There's so many things that can go wrong, but there are also, once your body gets the hang of it, there are a lot of things that can go right.
It's like riding a bicycle.
Yes. I have another question for you, which is, could you explore lean PCOS? So we get this question a lot in New York because we see a lot of it in comparison to other parts of the country, versus the standard overweight PCOS. Are they different groups? Are there different oral groups that are affected between them? I'm not quite sure what that means, but I do think it's a really good question to differentiate or talk about that, because we do see that.
I think it's a terrific question. And indeed, when I say that there are all of these different disorders that are thrown under this, circus tent PCO diagnosis, there are different groups. You have your overweight category, you have your lean category, you have your pre-diabetic category, you have your inflammatory category, you have your autoimmune category, and you're all under this 10th diagnosis of PCO. But that specific category of lean PCO, I believe, is a completely separate entity. Responds to similar therapies, but we know that their characteristics are often different in terms of the doses needed to stimulate the ovary, in terms of the evaluations that are necessary. When you look at that subgroup, when you look at some of these other categories of PCO, you have relatively high levels of FSH and LH, and the ratios could even be inverted. You are making more LH than FSH, and those hormones, again, it's a matter of balance. When you look at the lean group of PCO, there is a resistance. The FSH and LH levels in these groups are different than the other categories. So yes, they are different. As to exactly what the nature of that difference is, nobody knows. If you look at that standard category of PCO diagnosis, irregular menstrual cycles, hyperandrogenism, hyperandrogenemia, exclusion of what they fall into that group. But in all fairness, I think this is one of those things where a genetic understanding of the disease will be better able to sort out these different groups. I do think that they're a different group. How they're different, I don't know.
I'm wondering, I have a theory, and I don't know whether it's right or not, so I'm going to test it on you. I think I come across people who have a combination of hypothalamic amenorrhea and PCOS. And when I lecture across the country about Chinese medicine and fertility, and I talk about PCOS, I realize people in other parts of the country don't see as much of the lean PCOS as we do. And it occurs to me that New York women are quite driven, and I suspect have had weight problems, the beginnings of PCOS, and have dieted themselves, very disciplined, gone to the gym, that kind of thing. And so they have the beginnings of PCOS, and they've sort of headed it off at the pass, but they've gone into hypothalamic amenorrhea. And for those of you who don't know, hypothalamic amenorrhea is a disorder often caused by undereating and overexercising, where the pituitary loses its signaling. Again, all these nice communication systems get interrupted and people don't have periods. And I see a version that looks like PCOS without the estrogen dominance, which would make sense. And I wonder if it's hypothalamic amenorrhea and PCOS together.
Characterize that group very nicely.
Yeah.
They are not estrogen dominant PCO cases. And in terms of what the clinical challenge is, hypothalamic patients, they have very healthy eggs and they can mount a very robust response. And if they're masked as PCO, when you start stimulating them, you could get hyperstimulation very easily. For most PCO patients, you could hyperstimulate them very easily. But the hypothalamic PCO patients are the ones that really have a very profound and overwhelming response. It's very hard to manage. They are very tricky to manage when you're using gonadotropins.
They are for me too. I have one at the moment, and it's sorting it all out is complex. Emma has asked if she can hop on because she's going to ask some questions from the chat. Sure. Go ahead, Emma. Or not.
So we have a few questions in the chat room that I just wanted to flag as we're going through the other questions that were already submitted. So I'm just going to read this first one out loud. So the description is, I recently learned about the 100-day cycle of a follicle, and it makes so much sense as to why different symptoms of imbalances in our cycles can show up months after the actual root of the imbalance occurred. My question is, having this in mind, how long does it typically take for a patient to fully recover and heal their hormonal imbalance and reverse PCOS? I'm assuming it could take anywhere from 3 to 6 months to recalibrate our hormones and come back to the state of balance. And they wondered what your thoughts were.
I'm going to take that first, and then you're going to finish off for me. Good, I'm going to say this is very variable indeed, and not everybody can control this just with diet and exercise and supplements and things like that. But I'm going to give you something anecdotal that isn't clinical research, but I've done this a long time. If we can get our patients to have 3 regular cycles, which we actually are quite good at doing, we have noticed that their live birth rates go up. There are very high miscarriage rates, even if people do get pregnant with these eggs that have been sitting there and these long follicular phases. And if we can get the follicular phase, the part from your day 1 of your period to your ovulation as near day 14 as we can get it, and we do that for 3 cycles, our patients do much, much better. And I always assume, and I might be wrong here, and Dr. Mukherjee can correct me, but I've always assumed it's because the eggs, the follicles are less exposed to androgens at that point, that a lot of that has got out of your system. What do you think, Dr. Mukherjee?
I agree with you. I think that I don't have a specific number, but if we can reliably to get you to ovulate, 2 or 3 times in a row, then your fertility rates are going to go up, of course, right? Because we've taken an anovulatory situation, restored ovulatory function. And if ovulatory function is the only problem, assuming that there's no problem with the tubes or the problem with sperm, that should set you back on the track to successfully conceive. Now, reversing PCO, well, that's a little bit more dicey because, again, what is PCO? Don't know. If it's dietary, if it's control of hemoglobin, if it's hemoglobin A1C for insulin resistance, and you get your diet under control, you lose weight, and you're doing well, that's great. That's going to be reversed. If it's an intrinsic issue with the receptors, or there's something going on in an undiagnosed part of your system. If there is, let's say, an poorly understood thyroid irregularity that runs in the family, or liver dysfunction, so you're not processing your lipids and such, it's hard to cure PCO. You can treat it. You can get pregnancies through a number of different means. But in general, if it is linked to insulin resistance, unfortunately, as we get older, our insulin resistance worsens and our dietary habits suffer and we gain weight, and that that feeds into what causes the PCO condition in the first place for a significant number of PCO patients. It's hard.
And I just want to jump in here. Oh, you carry on. I thought you'd before Emma asks another question. I was just going to say that it's a good time to talk about acupuncture and inducing ovulation. There is good research that shows that acupuncture can help women with PCOS to ovulate more regularly. And the woman who did the research started by experimenting on rabbits. And apparently rabbits do not ovulate unless they're sexually active. I did not know that until I read this research, but that is true. And by doing acupuncture, she could induce non-sexually active bunnies to ovulate. And then they actually did the same acupuncture on women with PCOS, and it induced them to ovulate too. And the results weren't earth-shattering, but in a reasonably large group, 1/3 of women with PCOS started to have regular cycles with regular acupuncture, which is, good. It's not earth-shattering, but it's good. But they were the people who had a less androgenic hormonal profile, and they were the people who had less pronounced metabolic disorders. So they were already the people who were halfway there, and those people, acupuncture really induced regular ovulation in a way that I think, just from my own practice, those people, when they ovulate regularly, can get pregnant naturally, or are much better candidates for doing IVF with Dr. Mukherjee because they're less likely to be hyperstim.
Well, it's good to hear that. I wouldn't have been surprised if the high androgen patients responded as well. But I think that the group that you were focusing on, there may have been stress-induced abnormalities in the cycle, and acupuncture can certainly help reduce stress, help to bring the body back in balance, and take that 1/3 of patients to successful ovulatory cycles. So that makes sense.
Yeah, it's and the bunnies, I don't think, were stressed at all. So
the bunnies really cared, no.
Because acupuncture works in some ways on the sympathetic nervous system, and then it acts on the endocrine system, but also in the way that it's called hemodynamics, the way it increases blood flow and brings hormones to specific tissue and takes debris away is part of it. But I did just want to flag that because it sort of went on from that question in some ways. Emma, do you have another question from the chat?
I do. So we have another question, which is, if a patient is trying to conceive, after how many days without ovulation and/or menstrual bleeding would you recommend a patient takes Provera to induce a period and reset the cycle?
Well, I'll jump into that one. I would say that, if 30 to 40 days go by and you have a negative pregnancy test, of course, then I would not hesitate to initiate Provera to create a cycle withdrawal. But you don't want to administer any sooner than that, 30 to 40 days. Some patients who are not seeking to conceive, I prescribe Provera on a standing basis for the first 10 days or 7 days of the month so that they have a withdrawal bleed. The big medical concern is that if you do not empty the uterus for at least 6 months, you increase the risk of certain types of endometrial abnormalities, including endometrial atypia and certain forms of endometrial cancer. So I've had patients, and I'm horrified that they haven't had a period in 2 years. I'm like, don't you see your doc? These are the patients where I do an endometrial biopsy, I sample the uterine lining, I withdraw with Provera to empty that uterine tissue.
That's important to say, actually. Women are rhythmic, and if we lose our rhythm, there are consequences. And one of the consequences of living in that highly estrogenic state for any length of time is an increased risk of uterine cancer. I'm going to jump in here, Emma, because there's a question that someone sent beforehand that I think is interesting. What's your opinion of myo-inositol and PCOS? That's a question I get a lot, actually. Do you have thoughts? I have some.
There's so many different patients that are lumped under this diagnosis. I don't think that it's a treatment for everybody with PCO. I would say that certainly lean PCOs, perhaps, because there could be a dietary component, or patients who are not eating properly, if they need a dietitian, myo-inositol may be useful there. But for every PCO patient, I'm skeptical as to whether all patients would benefit from myo-inositol.
Well, I think it comes back to everything to do with fertility medicine, really, which is that there isn't a one-size-fits-all answer, because people are complicated and they have lots of things going in. That's why you need to see someone like Dr. Mukherjee, and in our case, as I get asked this question about myo-inositol a lot, and I have gone and looked at the research for my patients, and there are various supplements on the market. The most successful seem to be the ones that combine myo-inositol with folic acid. But you need to be careful that you don't have the MTHFR gene mutation and things like that. You need to, when you need a different form of folic acid, you need methylfolate. And there is research out there that reduces AMH levels. High anti-Müllerian hormone is a feature of some PCOS cases, and the size of polycystic ovaries. And there is some evidence that it reduces the risk of ovarian hypostim in women who are going through IVF. So that's interesting. And in a study of overweight women with PCOS that were given that combination of myo-inositol and folic acid during IVF, 32% of women had a successful pregnancy within 12 months, compared to just 12% who took a straight folic acid supplement without the inositol. So that, I think, makes some case for it. But you're absolutely right, aren't you, that it depends.
It does. I mean, the biology of it is somewhat convincing, but I think it's, the utility of it is, I mean, there's no harm in it. But again, there's plenty of foodstuffs that have come in and out of favor. I mean, CoQ10, DHEA, and so forth for other disorders, and they have marginal benefits. Again, for me, I would strongly recommend looking at their diet and seeing what they are eating. I think if they are, I would say that the institution of a Mediterranean diet would be of more use than taking supplements individually.
You and I are like mind in so much as I think people take too much stuff. And I do spend a lot of time. People come into my office with carrier bags full of stuff that they're taking, and nobody knows what that cocktail does. And so rationalizing what patients are taking is part of my job, I always feel. And bodies can get confused. I mean,
the other part of this, Jill, is that I did not have a lot of faith in herbal medications until I met you, simply because I didn't feel that the herbal preparations were made to the standards that are necessary for effective therapy.
Yes.
Well, after long conversations with you, I understand your approach and how meticulous you are in the preparation of these products. But which myo-inositol are you talking about? Are you getting it from, CVS? Are you getting it from, some online supermarket? I mean, you don't know just how effective these are. I mean, unless they're coming from a trusted provider, it's hard for me to say, go take some myo-inositol, because you never know what they're taking.
You do need to, I mean, it is a little bit like the Wild West out there when it comes to supplements and herbs. And Dr. Mukherjee and I have known each other for a long time. And he knows that at Yinova, we take enormous care over our herbs. They're made specially for us in California. And they are tested for contaminants and for efficacy of the active ingredient. And a lot of the problem with supplements is that they don't have as much active ingredient in as they say they do. At least it's not accessible.
There's a lot of money for some of these products.
Yes, and so then you just have expensive pee, and so it's important to get it from certainly our herbs, and we like to give people one herbal formula, not loads of things. You won't come to Yinova and leave with a carrier bag full of stuff. One herbal formula which we tweak as you change, and I think that's sort of the gold standard as far as I'm concerned. There is another question about supplements, and then I'm going to let Emma come back, but someone asked, are there any natural supplements that can help lower testosterone levels to help symptoms like acne? And I just want to say that NAC, N-acetylcysteine, does lower elevated androgens in my experience and in clinical trials. And again, you have to get it from a good source. Pure encapsulations are a good source. Metagenics are a good source. We have one in the office, but I do think that works. What about you? Natural supplements to lower testosterone?
Well, I think that if it is related to insulin resistance, it's really carbohydrate restriction and just change. I'm a big fan of modifying these type of issues with diet, specific supplements to some extent. But if you're worried about hyperandrogenism, well, what's the root of hyperandrogenism? If it is related to insulin resistance, it's carbohydrate intake. And you'd be surprised what people realize is a carbohydrate. And they'll have bananas and fruits. I'm like, well, that's very carbohydrate rich. And if you're consuming that in large quantities, yeah, it could be healthy for you, but depending upon the time that you're eating these foods, you're going to increase your carbohydrate load. That in turn is going to increase your insulin levels. Insulin levels are going to act on the ovary to increase theca cell production of androgens, and that's what you want to focus on. So you want to withdraw that stimulation. And to me, again, it's the rudiments of intermittent fasting, not eating, let's say after 7 o'clock, modifying the types of foods that you eat. Specific supplements to that end of some utility. I agree with NAC. I think that's a good idea. Yeah. But to me, the primary drive, unfortunately, has to be the tougher road. It's not a supplement. It's a dietary modification.
But, it's tougher, but it is empowering because it is something you can do. And both Tanmoy and I will tell you, we have plenty of patients who have conceived because they got really serious about a low carb diet. And it was amazing. It's amazing to watch how I can give people herbs, I can do acupuncture, but nothing gets the cycle back into line quite like dealing with your blood sugar when it comes to PCOS.
And that should help fully a third of PCO patients, because at least a third, it is linked to insulin resistance. And insulin resistance, it's not like you feel bad. Oftentimes you get a strong family history. My parents became diabetic in their 40s and 50s. And, that leads into the suspicion that you have the genetic predisposition for that. And you're best off taking measures to adjust your diet accordingly.
And when you take sugar out of your diet, and I like sugary things myself, it is amazing how addictive sugar is. So lots of patients tell me going halfway doesn't work, but if they just take carbohydrates out of their diet, within a few days they don't miss them unless they sneak something in, and then it sets off a blood sugar imbalance. That means they start to crave it.
I've had endless discussions with our dietitian who we have on staff about sugar, and we both agree that sugar is insidious. It's in every food. There are, a slice of pizza. The last thing you think about is sugar, but there's the equivalent of about 3 chocolate chip cookies worth of sugar in a slice of pizza, just in the dough alone. So,
if you take nothing else away from this webinar.
I love pizza. Don't get me wrong. I may be having pizza tonight. It all depends. But
if we're wanting you to have regular periods and you have PCOS, then really limiting your carbohydrates.
Mediterranean diet with salad, leafy vegetables, protein, it does work. I'm not in for miracles, but it works very well.
It does. It does a remarkable job, and it's fun to watch a patient really do that. And although having to change your diet is hard, it's also very empowering because it's something you can do. Now, Emma, do you have more questions from the chat?
I do. I'll dive right into this next one. So someone said that I'll just read it as they wrote it. I've officially been diagnosed with PCOS, but have also been suspected to have functional hypothalamic amenorrhea. I'm wondering what Jill thinks of this, since we touched on this. I'm also currently one of her patients and love her.
And I don't know which one that is because I can't see the chat at the moment. But yes, I have several of you who have hypothalamic amenorrhea and PCOS at the moment. So it's, as Dr. Mukherjee said, it's tricky. It's tricky for me and it's tricky for him. And what I usually do is we start with the hypothalamic amenorrhea. And we start by cutting back on the exercise and the very severe calorie restriction, if that's the root of the hypothalamic amenorrhea, because then I can see the PCOS better and start to treat it. And I put people on a formula for PCOS. I have herbs that literally break the little waxy coat on the cysts, which is really interesting. And you and I should study them at some point. We should do a study because it's really interesting. So this is what you can do if you tailor a herbal formula for every patient rather than pulling something off the shelf. I give them a formula for hypothalamic amenorrhea that also has herbs for these little reducing cysts. And then as I start to establish a cycle, it's usually a long cycle to start with, I start to give different herbs in the follicular phase and the luteal phase. And I'm doing that on Zoom with lots of people at the moment. I have quite a gang. We should have a support group, actually, which makes me want to say something. We are starting another round of the Yinova fertility coaching and support group, and it is enormously good value. We give you a free treatment. If you're my patient, you're not supposed to have a free treatment with me, but you can. Just tell them Jill said that was fine. It's Emma will tell you how many weeks. I think it's an 8-week course, and it covers all the basics of getting pregnant, and it has all the best bits of being a support group because you have people with you going through the same thing that you can talk to, but it cuts out the worst bits, which is that support groups can get gloopy because everybody's working on a project. Dr. Mukherjee comes and talks to you one week, and it's the people who did it last time loved it. Emma, is it 8 weeks long, or did I imagine that?
No, that's right. It's 8 weeks long.
It's led by 2 of our senior Yinova practitioners, Anne Bran and Mary Hammerway. They're awesome. They're very experienced fertility practitioners, and they'll teach you BBT charting and how to recognize your fertile cervical mucus. You can have long discussions with them about supplements and things like that. You can hang out with Dr. Mukherjee one week. I think there's a therapist comes one week and talks about how to handle the stress of trying to get pregnant. And I have to tell you that the last support group loved it so much that they've carried on meeting without us. They get together on Zoom, even though they're not part of the coaching group. So that starts next week. And I think there are just a few places left. And after I've said this, they might fill up. So who do they book it online? Emma, did you put it in the chat?
Yeah, I put a link in the chat. I can also put my email in the chat room as well. And you can find out more that way or by emailing me at emma@yinova.com.
There you go. She's popping it in the chat. Now, do we have another question, Emma?
We do. We had briefly touched on insulin resistance throughout this talk, but someone was wondering if we could dive a little deeper and if you could share what some of the symptoms would be or how someone would know that they have that.
That's a great question. You know, it's very hard to diagnose clinically, believe it or not. I think weight gain, despite maintaining what you think is a reasonable diet, would be one clue. What would steer me to be very concerned is if you have a strong family history. If, you know, both your parents had diabetes as an adult, then you probably have some element of insulin resistance. So what does this mean? Insulin resistance means that for a set amount of insulin, your body over responds, and you keep making more and more insulin to get to this same state, and your body keeps cranking up this response to insulin. So you're making very high insulin levels. Every cell in your body is revved up. For PCO purposes, the ovarian cells are seeing these very high insulin loads and making more androgens, and that initiates this hyperandrogenic environment. But the best way to test for it is to come in for a fasting glucose level, for a fasting glucose insulin ratio. There are more advanced tests where glucagon is administered, but the primary means of looking and making that diagnosis is blood work. in addition to a family history or history of easy fatigability, weight loss, frequent urination even, and by that point you're getting pre-diabetic. But in general, the evaluation should be done at a routine visit. You may not feel the symptoms of insulin resistance at all.
I do think that the unfair weight gain is a real, I call it unfair weight, because you know what fair weight is. You know when you've indulged and you put on weight, and that's kind of fair weight gain. But a lot of patients with PCOS tell me, you know, I feel like I have to work so hard to stay thin. And, you know, the least little thing I eat, I put on weight. And so that's always a warning sign for me to send them to see someone like you, actually. And find out what's going on. Do we have another question, Emma?
Another question. So someone would like to know, would you categorize PCOS as a form of diabetes or perhaps the cousin to diabetes? Diabetes runs in their family and they've had a ton of blood work done and they're not insulin resistant, but they have always struggled with keeping their weight within normal range. What would your thoughts be?
Well, again, I would say that there is some portion of this PCO diagnosis that are pre-diabetic states. And I think you have a strong family history of diabetes. Both parents are affected, they're taking glucophage or other medications, or they're on insulin. Then you probably have a genetic predisposition to it. And even though you haven't tipped into that category of being insulin resistant yet, you do have the genetic basis to develop it relatively quickly. And thankfully, your blood work is in order. But I would say that this particular category would benefit the most from dietary intervention early, before it gets to that insulin resistant stage. Mediterranean diet, intermittent fasting, not eating after 7 o'clock, elimination of sugar. These are things that I think for this particular category of PCO that hasn't manifested diabetes or even insulin resistance yet, but they have the genetic predisposition for it from their family history. This is where these modifications, I expect that to be a full third of the patients that we call PCO. They're going to benefit tremendously from those type of dietary interventions.
I have a question here that came ahead, and it's I don't have most of the typical symptoms of PCOS, but an ultrasound confirms cysts on my ovaries. Do I have PCOS?
If you have regular periods, no. Because that's the very first criteria. I've had lots of patients, oh, my doctor says I have PCO. Oh, how often do you get it? I get them every 28 days. Have you had any problems getting pregnant? No. But my doctor says I have PCO because my ovaries are really big and they have lots of follicles in them. You have nice healthy ovaries, congratulations, but you don't have PCO.
Correct me if I'm wrong, but it's a 2 out of 3 thing, isn't it? It's irregular menses, elevated androgens, and cysts on the ovaries. If you have 2 of them, then they normally die.
Criteria called the Rotterdam criteria that use those ultrasound findings, but the NIH consensus that doesn't use the ultrasound at all. It's irregular periods, hyperandrogenism, hyperandrogenemia, and then exclusion of other medical problems. Then the Rotterdam criteria does have the ultrasound characteristics of having lots of follicle string of pearl appearance. I think it's 8 subcapsular follicles on both ovaries. So it depends on who you use. I've always used the NIH consensus, which doesn't have the ultrasound part of it, because not all people have access to ultrasound to make that diagnosis. And I don't really think it's necessary either, because if you have these criteria, that's what matters to me, no matter what your ovaries look like, right? Because again, I have patients of regular periods, but the doctor sees that they have all these follicles and say, you have PCO, but no, you really don't, because you need that first part of the diagnosis must be met. So it's in order of stringency. The first part of it must be an anovulatory or irregular menstrual cycle pattern.
That is a good way of explaining it. And someone else says, is there a correlation between PCOS and repeated early miscarriage? And there is, isn't there? Yeah,
there is. Unfortunately, PCO has a lot of manifestations, but it goes back to the elaboration of progesterone. Progesterone is a critical hormone in the maintenance of pregnancy, and high androgen levels are not ideal for ongoing pregnancies as well. So by correcting the PCO pattern where you're making it a pro-estrogen environment to a point, lowering your androgen levels, increasing progesterone in the early part of pregnancies, I routinely start progesterone on my patients who have a PCO diagnosis. Or I try to.
Emma has a miscarriage question from the chat too, so it'd be a good time for her to interject with that. Emma.
So I'm just going to read it out as it was written. I've had 2 early miscarriages and 2 ectopic pregnancies. Underwent, actually, I apologize, I don't know how to pronounce this. Underwent left
salpingectomy. Yeah.
Thank you. Sorry. Now I've done qualified nutrition, strengthen training, meditation, and acupuncture. I've lost 25 pounds. Now I'm scared if I will have a miscarriage again when I try to get pregnant. What tests or hormones should I do next time to get pregnant to avoid miscarriage?
Oof, that's a very tough situation. And unfortunately, there's nothing that you can do to eliminate the risk of miscarriage. But in general, you should have a separate miscarriage evaluation. If it is related to PCO, then supplementing progesterone levels would be very useful. In these groups of patients, I do use a little supportive therapy, a little bit of baby aspirin, not 100% proven to be effective, but because there's a little harm in it, and folic acid, methylated folic acid, 1,000 micrograms a day. So that's my usual approach to a history of miscarriage. But if it's a chromosomal abnormality, then none of these interventions are going to be effective, and nor should they, because the pregnancy does have a chromosomal abnormality. And people don't realize it, but in your 30s, your risk of having a miscarriage due to a chromosomal abnormality is as high as 15 to 20%. So that's why, as much as we'd like to avoid all miscarriages, because they are very difficult issues to deal with, we really can't outside of IVF, where we screen for embryos. And I'm not saying that you need it, but if there is an issue with the fallopian tubes, you've had 2 early miscarriages, it may be something to consider.
I just wanted to, I want to say sorry, because I know how hard that is, and the ectopics too. You've really been through it. However, you have done some things, according to that question, to make a difference. And the weight loss, I think, will be a huge help. And my own experience is that you are less likely to have miscarriages once you get the cycle of metabolic issues and hormonal disruption under control. And so there's reason for hope. And you know, Dr. Mukherjee's right. 60% of miscarriages are caused by chromosomal abnormalities, and you know, the destiny of an embryo is set before we even know or can intervene. But I do think that everything you've done, I don't want you to be scared moving forward. You know, I want you to have confidence in what you've done, because it's already bearing fruit. And you can know that that's going to help your reproductive status, and that you're much less likely to have a miscarriage. We can't, you know, we'd love to wrap you in cotton wool at this point and try and prevent you from having another one, because we know you've been through it. But you're much less likely. And I think you should take that with you, that, you know, don't give up, move forward, and everything you've done is going to help.
You're absolutely right. That weight loss is going to be very helpful.
Really helpful. Emma, do you have another question? We have, I think, room for 1 or possibly 2 questions.
Let's see here. Okay, we have one about someone, a 24-year-old patient who was diagnosed with PCOS by Western medicine with no typical overt symptoms of PCOS, and was in the thin type that Jill had described earlier. A practitioner has said, by Chinese medicine standards, she was spleen-yang deficient with a predominantly cold diet and overexercised. Within 3 months of herbs, elimination of salads, only diet, and lessening exercise, she began to ovulate and menstruate regularly and had 2 children with no other interventions. And they wondered what Dr. Mukherjee would say about this type of case.
I think that's terrific. I'm not an expert on that type of medicine. I'm going to let Jill field that. I think that well done.
No, we all have lovely, happy stories too. And thank you for sharing that one, whoever it was who's a Chinese medicine practitioner. I gave an interview to Emma for our blog the other day. I have a patient who continues to write to me on her children's birthdays, and they're now in college. So you can see how long I've been doing this. But she had PCOS, and I actually based the chapter in my book, Making Babies, on what I learned by dealing going with her. And she went on, she was told at one point that she had a less than 1% chance of conceiving. She'd had many failed IVFs, and she also had endometriosis. She had a lot going on. And she went on to have 2 healthy babies. And every year on their birthday, she writes to me and sends me an updated picture of whichever one it is their birthday, and every year I cry when I read her story, and she says, I always think of you on my children's birthdays. So yeah, Chinese medicine could be really helpful, and it's lovely to hear a story like that. And what spleen yang deficiency is for everybody else is really a sluggish metabolism. It's our way of looking at a sluggish metabolism, poor fluid metabolism, and insulin resistance. So we have a whole way of saying it, and we have herbs for it. So I think we're about to wrap up, but is there anything very urgent in there? I know you can't get to everything, Emma, but is there anything that you would like to ask us?
There's one last question that I think we could maybe squeeze in, and then we can wrap it up, if that works for you both. I'll read it out right now. So I have PCOS, and my husband has abnormal morphology. We are both taking necessary steps to heal ourselves, herbs and acupuncture. I know sperm comes to fruition every 3 months. Should his sperm analysis be retested at some point? And does this make it more difficult for us to conceive?
Yeah,
yes, it should be retested.
Absolutely. 3 months. Yeah.
Yes. Every 3 months. You go.
Oh, I'm sorry. So yeah, morphology is very important. You think of the sperm and the egg like a lock and a key. And if that morphology percentage remains, you look for, on average, it's 6 to 7% of the sperm population should be normal in shape. If it's less than 4%, you start to see declines in fertilization. So once all these interventions have been established and you're consistent with them, I would retest the sperm in 3 months, because it does take about 70, 80 days for new sperm to form, and make sure that that morphology is bumping up. If it remains low, you may need to seek additional therapy.
And I would give it 6 months, because the first 3 months, 3 months is just from the beginning of his regimen. And the nice thing about men, there are lots of nice things about men, but the nice thing about treating men when it comes to fertility is this idea that they make new sperm every day that come into fruition in 3 months' time, because lifestyle adjustments and changes that they make to their diet can really affect their reproductive status. And men have a tendency to think that if they've fathered a child once, then they're just fertile, like it's very flat. But actually their fertility goes up.
10 years ago. Yeah.
Yes, they do. We've all been there with patients, but it's not like that at all. Their fertility goes up and down depending on the stressors on them, both physical and emotional. And so a lot of the work that they do can really bear fruit, literally bear fruit. So I commend him for doing that, and I think that is my patient. Actually, I recognize that case, because I have a patient with PCOS with husband with low morphology, and she's a love, and I am rooting for her and him, and we're taking them in hand.
Excellent.
All right, well, I think we have covered a lot of ground, Dr. Mukherjee. And I only see you on Zoom these days, which is sad, but...
That's how we see a lot of people these days, on Zoom.
Eventually, I'll come back in the clinic and see you. But you should just know that I adore Dr. Mukherjee, and I sent him lots of patients. We collaborate a lot. He's a fabulous doctor. You can see that he's really good at explaining things and making everything accessible. And those good communication skills are so important in a reproductive endocrinologist. And he has just, I can say, because I've watched so many of his cases, he has really good clinical judgment. I send people to him and don't lose a wink of sleep, because I know they're going to be really well looked after. And so should you need a reproductive endocrinologist, I recommend him highly. And we are all back at work at the Yinova Center, both in Brooklyn and the Flatiron, and right round the corner from RMA at 58th Street, where we see a lot of RMA's patients. So come on in and see us. We're also doing virtual. You can book an appointment with me virtually, which I didn't see new patients for a long time because there's a big team at Yinova, but I am back. and happily troubleshooting people's fertility issues online.
That's excellent news.
Oh, and sign up for the Yinova fertility coaching and support group. It's really good value for money. I think it costs the cost of 2 treatments with us, and you get 1 treatment for free. So, and you get all of that information that we never have time to tell you in clinic that we wish you knew.
Jill, thank you so much. Thank you for having me. Thank you for putting up with me for an hour. But my patients adore you. They love working with you. Yinova provides services that I can't compare to anybody else. They're great environment, knowledgeable practitioners. And again, always a pleasure to collaborate, to speak with you, to see you on Zoom, and glad to see that you're safe and healthy. Thank you for having me. Have a good afternoon.
Thank you, you guys. And we wish you well. Dr. Mukherjee and I, we wish you much luck in your fertility and your PCOS journeys. And we're right here if you need us.
Right. Email with any questions. Take care.
Bye.
Bye-bye.